So today our topic, as Heather mentioned, is going to be narrow networks, and we're going to discuss a couple elements around that and hopefully give you some good information to leave from today's session with. So just to quickly reiterate, my name is Travis Turner. I'm with Corporate Synergies. I'm on the client service side, what we call the account management side, and I'll be talking a little bit about narrow networks from a high level, talk about how we view them from a consulting standpoint, as well as some of the elements that go into assessing whether a narrow network might be a good potential fit for your benefit program. And we're also very excited to have Drew Thompson with us from Northwell Direct. He's going to be able to talk a little bit more about the building and management and strategy behind a narrow network. So Drew, I'll let you take a minute to introduce yourself as well.
Sure. Good afternoon, everyone, and thanks for having me. Excited to be part of this call today. I'm Drew Thompson, the head of sales and account management at Northwell Direct, which is Northwell Health's direct-to-employer arm, whether it be at-work services where we provide clinical and on-site services near site, virtual to employer groups, as well as what we're talking about today, a network, a provider network that we developed through our health system, our parent company, Northwell Health, that consists of over 25,000 providers, 53 hospitals, urgent care, every single point that a member would touch throughout the care continuum. So happy to be on the call and looking forward to the discussion.
Great, thanks, Drew. And we really thought that would be the most helpful way to really address the topic, is to look at it from a couple different vantage points and bring in an expert who's had an opportunity to really get in there and develop this type of network and give some real life examples for what we'll talk about, really on a strategic and high level, and dig into a little bit more detail and hopefully give you some good tidbits to take away from today's session. So when Heather kicked us off, she gave a very quick agenda that I'm just going to recap, for us very quickly here. But we're going to start with really looking to define what a narrow network is. We'll talk a little bit about that. We will then transition into talking about how narrow networks can be integrated into a benefit program and some of the considerations that you might have as you look at narrow networks. So we'll have that definition, we'll talk about integration, and then we're going to talk a little bit about elements beyond just the network itself. So you'll hear terminology and we'll define some of these things, but in many instances when we are talking about these type of network solutions, it's more than just the network. There are other components that are built into these types of programs that are also essential, and we'll talk about those. And then we're going to conclude today with discussing how do you assess a narrow network? What are the steps that you would want to take to determine if it could possibly be a good potential fit for your organization, for your people, and all the considerations that go into that. So with that, I'm going to move us into our next slide here and really start with a very basic definition to kick us off, which is a network itself. So a network, as I'm sure everybody that's on today's webinar knows, is a listing or grouping of medical providers and facilities that are contracted to work with a particular insurance program or a particular organization or group. And then members of that either insurance policy or group then have access to these particular providers and facilities. And there's also contracted or preferred pricing that's part of that network analysis. So that's a baseline. I'm pretty confident we all know what that is. So now we move into the terminology around a narrow network, and we use it in a very broad sense, generally speaking, because you'll see multiple definitions for a narrow network. And at its core, it just means that it is a network that's focused in some way, shape, or form. And that focus is usually around a couple different areas. And we've listed those out here at the bottom for you to see. Geography is an important focus for a narrow network. Another element that a network might focus on is outcomes. So measuring the results that the providers are able to bring to their patients and to the members of the network. And then also looking at the cost components of a network. There are ways that the contracts that are developed with a particular provider or a particular facility might be structured in a different way with a narrower network than they would with a very broad network. And in many instances, and you'll see this as we dive into some of the details today, these networks are comprised of a combination of these factors. So we're usually going to be looking at all three of those elements: geography, outcomes, and cost, when we're talking about a narrow network, and not necessarily one given element at a time. And in fact, when you're assessing narrow networks, you should expect to have information and data points on all three of these categories, because the most effective narrow networks will also be looking not just at geography and cost, but also at outcomes, health and wellness, patient support, etc. And we even sometimes hesitate to use the term narrow, because it can almost feel like there's a negative connotation there, that you're pulling back or you're restricting something, and it could be seen as like a takeaway for employees. But we want to try and broaden the concept around that, because even though we're using the term narrow network, we're many times talking about a focus network. And even though maybe depending upon geography or contracting, there might be limitations on where members or patients can go to access the care, but there could also be additional benefits they realize in other areas, perhaps at a lower cost, or a more white glove type of approach to benefits, where there are additive elements of a narrow network as well. So for today's discussion, we're going to stick to that terminology, but we don't want you to necessarily think of that as narrowing. It could actually, be the opposite. It might be more of a compromising, right, to get what you're looking for out of a network. But we're going to dive into that, talk about that in a little bit more detail as we go through today's discussion. But we want to start with the value of a narrow network, just at a very high core level. What is the value proposition behind a narrow network? And a lot of it does start with pricing. With networks, with any network, but specifically with what we're going to talk about today, there are arrangements with the providers and with the facilities. And in these types of arrangements, there might be more competitive contracts in place that can provide aggressive price points, right? So if that price point can be competitive and can be lower than what we're looking for, most of the strategies that we talk about are around cost containment and cost mitigation strategies. And this is certainly one of those. So you need to make sure that competitive pricing is a part of it. Another piece is network steerage. So beyond just the contracts that are in place with given providers, the element of the network that goes beyond that is where employees are going to access their care. So if there is an opportunity to encourage plan members, patients to go to facilities that have perhaps better outcomes or better cost, that network steerage can be ultimately beneficial in a long term. And we're normally looking at where do we want to steer network utilization on the same type of criteria that we were just talking about on our last slide, which is the geography. So there might be geographical elements where we want to steer utilization, or outcomes. Again, cost becomes a significant part, and a combination of all of those things. So there are steerage elements that will impact utilization that also can bring a long-term value to a narrow network. And the final bullet point that we have here is sustainability. This strategy is geared to be ultimately a longer term or multi-year strategy. It's not, although it can be, it's not typically employed as a short-term solution, because there are steps to put this in place, there are steps to analyze it, and there's education that goes on for the plan members, and that requires all collectively quite a bit of effort. So if you're going to go through all of those steps to put in a program like this, you want it to be sustainable. And if it is the right fit, it does have the competitive pricing, you are getting the type of network steerage that you're looking for, these programs can be sustainable, because they may not have the same level of average increase with the cost of the plan from year to year, like we might experience with a broader network that doesn't have the same factors built into it and the same level of control that's going on. So one other piece that I just wanted to touch on here, a lot of what we're going to talk about today is geared around self-funding. And so that's when you're, as a plan sponsor, as an employer, you're paying for your own medical claims, and you have an administrator to adjudicate your medical and your prescription claims. But these solutions are not exclusively self-funded. So when we talk about narrow networks, there are fully insured narrow networks, there are self-funded narrow networks, and there are narrow networks that are kind of in between. So you don't want to automatically assume that you do or do not have access to these types of programs, or that they may or may not be the right fit, just dependent upon how the funding strategy is set up for your existing plan. So a lot of what we're going to talk about today, like I mentioned, is going to be around self-funding, because it will give you the most options as you look and assess. But we'll talk about when you do your assessment of narrow networks, wherever you are on that funding spectrum, there are going to be options that you're going to want to explore. They may just be more limited depending on where you are on that spectrum. What we'll do now is, as we're kind of talking about the value in the application, I'm going to give Drew an opportunity here to walk us through a little bit of the history and the value that a narrow network, specifically with Northwell Direct, can bring and has to its clients and employers.
Great. Thanks, Travis. And as you were speaking, I was going down memory lane a little bit, thinking about 15 years ago, 20 years ago, when provider networks were just being established and regional networks were just being established. The size of our narrow network at Northwell Direct is the size as those networks were 15 years ago, right? The networks have expanded through acquisitions and consolidation of regional networks, but I think it was a really good point you made around that it can be a focused network where you have access in a geographical area, you have the quality metrics. So those are things that we're always constantly focused on. So I think it was a really good introduction of it's not narrow network in the sense that you lose that access component. It is something that is certainly large enough to offer to an employer group on a standalone basis, as well as a tiered approach we'll talk about a little bit later. So anyway, yeah, as you can see here, I think everyone is pretty familiar with the rising cost of healthcare trend over the last 20 years. I think right now, in the state of inflation where we are, just in general as a country, with a gallon of milk going up year over year, or gasoline that we've seen in the last 2 years, you see the inflation that everyone is seeing top of mind in their everyday lives. But this is the world that we've been living in for the last 20 years, with benefit administrators, for companies, for insurance carriers, for payers, providers, where we're seeing annual trends of 6, 8, 10% year over year healthcare inflation. And as Northwell proper, the parent company, the health system here in New York, being the largest private employer in the state of New York, the 7th largest health system in the country, we do get approached a lot by business leaders, different folks in the communities that we serve, saying, hey, we're struggling with our healthcare plans. We're struggling with budgeting every year over year for insurance costs. It's our second or third biggest line item for our business. You guys are part of the healthcare delivery system. How can we stop this year over year increase? It just seems unsustainable and unaffordable. So, Northwell Health, about 4 or 5 years ago, started incubating the idea of Northwell Direct to provide a solution to self-funded employers for their healthcare spend and acquisition. So if you flip to the next slide, we can get into a little bit of the thought process that went into what we'll call direct to provider contracting, or direct to employer relationship. So we took a look at what was going on throughout the country. And I think a lot of folks on the phone today aren't sitting just in New York, in downstate New York, where we are. You might be in Philadelphia, you might be in the Southeast, you might be out west in California, but large companies were making direct relationships with these large health systems that you can see on the screen here. And what we did is we thought that instead of making a relationship with a massive health system, 80,000 employees across many different counties, many different hospitals, many different administrators, let's start a business that all that we do is speak directly to businesses every day. So it's that direct to employer relationship, working with consulting partners like Corporate Synergies to provide a benefit offering to them. But what we looked at was that, you can create a relationship from a healthcare standpoint with a health system, and it doesn't have to be complicated. So what we did is we started a network, like I mentioned earlier, 25,000 providers, but not just Northwell. We went around to different areas in the New York metro region and contracted with other health systems. So, for our footprint in northern New Jersey, we have RWJ Barnabas, their 12 hospitals and about 4,000 or 5,000 providers in that catchment area. Montefiore in White Plains and the Bronx, as well as Maimonides in Brooklyn, and a bunch of other large independent physician practices. But the whole mindset is we know what we're being paid by, when I say the Bucas of the world, Blues, United, Cigna, Aetna, and let's be able to go directly to an employer and drive savings for them and negotiate rates with our health system and our health system partners that are in aggregate around 20% less than what the reimbursement rates are from the BUCAs, the payers, in the big four in the national landscape. So what we see is, for the same services, the same physician, the same facility, for a self-funded employer going direct to Northwell Direct or the other health systems that you see here on the screen, and this isn't exhaustive by any means, but I just want to give you guys some perspective. You'll be able to get better rates and a better control of the quality of your health plan. So what happened there is that, you have these large Fortune 100 companies doing this, and they've been doing it for quite some time now. And now you're seeing it trickle down to the small to mid market. So we serve employers anywhere from 100 lives to be honest with you, roughly 4,000 or 5,000 lives in our New York metro region. We have other relationships with companies like Whole Foods for the members of their company in this area. So they've done a carve out to Northwell Direct for their 6,500 employees, but they're tens of thousands nationally. So if you're an employer really at any size, small to mid market, 100 plus in New York or 50 plus in other states, and you can be self-funded, or like Travis said earlier, there's other different ways to acquire a narrow network, whether it be fully insured or level funded. You can create that relationship and I think both drive quality and cost efficiencies for your health plan.
Yeah, that's great. And Drew makes a couple good points. Some of the logos that we see on this particular slide, they're large companies, but there are solutions that are now becoming much more accessible to that mid and smaller marketplace. And what we're also seeing is combinations of strategies. Basically, what I mean by that is that a lot of what Drew has described and some of the network and the focus of Northwell Direct is around the New York metro area. But irrespective of where you are geographically, you may be able to find that network solution wherever your employees might be. We have found that, especially in the last couple of years, the workforce for most of our clients has really spread out significantly. So when we talk about some of the analytical components that you want to review as you assess narrow networks, the starting point is to figure out, where do we have a significant footprint where we could actually make this work, where there's a narrow network option. Right. So even though Drew is giving us some specifics around the New York metro, if you've got a bulk of employees in Chicago or another, particular area geographically, it's all about finding what the fit might be in that particular area, and tapping into that and seeing if it's going to be a good solution for you. So that was very helpful. So as we think about the strategy behind a narrow network, like with most of the topics that we have on our webinars, and as if you've worked with corporate synergies, we will frequently start with laying out your core benefit strategy and your core goals. So as you think about your strategy and your goals for your benefits, the logical thought process is to determine, how do we integrate a program like this? Because Drew mentioned some really positive numbers, being able to contract at rates that are 20% below what some of the major insurance companies are contracting. So that number is pretty appealing. So there's value there. And then, that logical progress of how do we integrate that? I think many times when we start to have this discussion and we talk about the geography and we talk about the application, the natural thought is to think about, well, that wouldn't necessarily work for us because we're too diverse, whether it's too geographically diverse or too diverse from an opinion stance or whatever it might be. And that's okay, because these types of programs can be integrated into an existing benefit strategy, not just replacing a benefit strategy. So as you think about how you could get something like this to work for your organization, if it is, a potential fit, there are ways that you can integrate benefits so that you can still be flexible in what you offer and comprehensive in what you offer, but integrate the narrow network concept into that. So I'm going to actually pass it right back to Drew again to talk a little bit more about some of the ways that they have integrated narrow networks into employer benefit programs.
Great. Thanks, Travis. Yeah, so what really this slide is going over is the three different benefit strategies that we have. And really what we see employers adopting these different strategies kind of based on their size, right? So as I go through these three, full replacement, we see more on the lower end of the market, companies 100, a couple hundred lives. Then all the way to the right, the slice offering, we see jumbo employers like a Whole Foods, which we'll talk about, taking that offering. And I'd say 90 to 95% of our clients fall in the middle. And we'll dive into that. And there's actually a slide later on that goes into what a tiered benefit strategy is. But with all these different options, you can, have the network be just Northwell Direct and have it the small, high quality performing network. Or with a tiered benefit option, you have the ability to not cut your access at all from what you're offering today with a national provider network for people here locally, as well as throughout the country. And I think, we all understand that the landscape of where employees are living coming out of COVID is vastly different than it was 3 or 4 years ago. So we have to be mindful of where people living outside of a narrow network core catchment area, what network they can access, right? So you might have 20, 30% of your population not working around where your corporate headquarters are. So any narrow network that you might be looking at, you have to make sure that you're providing adequate coverage and access to those members living outside of the core catchment area. But a full replacement strategy is just the way it sounds. These are employers that are looking to drive ultimate savings, the 20% negotiated contracts, the savings I was talking about earlier, for every single claim that they see come through the door. And what do I mean by that is that Northwell Direct would be the sole network for the catchment area. In our example, it would be the New York metro region. And then we would have a wrap network for anyone living outside the area. But if you live in the New York metro region for us, you'd have access to only Northwell Direct. So if you're gonna, for example, if someone wanted to go to a hospital like Sloan Kettering, it would be out of network. This drives the most savings. This is for an employer that says, my budget is strapped to the max. I need to drive, ideally, 100% of my utilization to Northwell Direct and receive that 20% savings. So I'm going to take this option. The far right is what we call a slice offering. So I mentioned Whole Foods earlier, but what they did and what we see other large employers do when they have a very large population in this area, or just, a population that makes sense for them for their budget, but they have people living outside of the area and maybe, 50% of the people living somewhere else. They say, you know what, for our people living in your catchment area, for us, the New York metro region, we are going to offer you guys alongside our existing national carrier. So what Whole Foods did is they said, we offer Blue Cross Blue Shield to the whole country, everyone that works for us. In New York, we're going to give them that option to choose between Blue Cross Blue Shield as the administrator and Blue Cross Blue Shield as the national network, or the Northwell Direct option. And what they do to incentivize employees to choose the Northwell Direct option, knowing that we have that network savings differential and advantage compared to Blue Cross Blue Shield, they offer a richer plan design than what is offered by Blue Cross Blue Shield, as well as have a richer employer contribution to that plan as well, to promote an election into Northwell Direct over Blue Cross Blue Shield. But they want to have a consistent message nationally that we are offering this narrow network in New York, but we're offering Blue Cross Blue Shield as well and to the rest of the country. So if you're thinking about that strategy, you want to put a process in place where you're going to incentivize your membership to choose that narrow offering where it makes sense for them, whether it be their paycheck, richer plan design, or both, knowing that if you have a $200,000 claimant or a $300,000 claimant, if you could save 20% on that on the back end for the same hospital, same provider, same facility compared to a national carrier network, that's going to offset the incremental payroll contribution from the employer, as well as the additional benefit, the richer benefit. But then we'll go into the tiered option in the middle. Like I said, this is our most popular offering. So what we're able to do here is create a tiered approach. Hospital systems have been using this model forever, right? And if you think about it, if you're a hospital system, you provide the services where your members are accessing that care in your own health system. So you don't want your employees going to your competitors down the road or in the other county, or in our area going into the metropolis, New York City, to other specialized places for care. So what health systems have done is they create a domestic network, which they call Tier 1, and Tier 2 is a network for anything outside of their health system, but they want to keep that spend domestically in their systems. They offer better benefits to go into that tier, lower copays, lower deductibles, better co-insurance, but they still want to provide access locally and nationally to the broader ecosystem. So they use a Tier 2 network, still in network, for hospitals, providers that are outside of their hospital system, for members to access that care, still in network, still with copays, still deductibles, still with co-insurance, but at a more out-of-pocket cost, or a higher out-of-pocket cost to the members. So if we flip to the next slide, Travis, we can show exactly what we did. We took that model and used the Northwell Direct network, as well as our 2 relationships nationally with national insurance carrier networks, to develop that same model where we're trying to drive the steerage and utilization through Northwell Direct, but still provide that access to that national carrier network, both locally and nationally. So you see here, when we offer a model like this, you have the Tier 1 Northwell Direct benefits on the left. The Tier 2, in this example, it's the Aetna Signature Administrators Network in Tier 2. You see there's a lower deductible, lower copays, the best co-insurance on the left-hand side, and on the right-hand side, still a network, but higher copays, higher deductibles, and leaner co-insurance. As a member, we get asked this question all the time, you don't select a network at open enrollment. You have the flexibility to go in Tier 1 and Tier 2 throughout the year. I can start at a primary care physician in Tier 2 and go see a specialist in Tier 1 and have that procedure at a Tier 1 facility throughout the year. I can go in and out, and all the while, for the member, you see at the bottom, these costs in each tier are cross accumulating to one out-of-pocket maximum. So you have that ability to have a member go to a Northwell Direct network provider or facility, but then go to hospitals for special surgery in the New York market, or Sloan Kettering, right? That would still be a network. The member just pays a little bit more through their out-of-pocket costs, through their benefits design in Tier 2. And what we see is, given the strength of the narrow network, a lot of employers adopt this model. And what they do is, from an HR standpoint, it's a lift, because the network essentially is not getting smaller, but they will match the current in-force benefits as Tier 2, and know that they're driving savings by having that utilization go to Tier 1, and provide an increased benefit for that tier. So they can go back to their population saying, hey, we're adopting this model, this tiered approach, but your benefits are going to stay the same for Tier 2, but we're actually giving you a richer benefit for Tier 1. And the employer, the self-funded employer, knows in the back end that for those facility claims or those outpatient claims, those large dollar claims, when they can save 20%, it's going to make up for that plan differential on the back end by leaps and bounds.
I think that's a really great point, Drew. It kind of ties into what we talked about earlier on the, on the onset of our discussion, which is, even though it's the introduction of a narrow network, you're able to expand upon the benefits for an individual by offering them lower cost share. So if done effectively and in the appropriate situations, this could actually be, positioned and additive, and as a benefit enhancement to employees when that fit is there and when it is the right option at the right time by using that tiered approach. And a
Right.
solution like this also helps, I think one of the biggest concerns when we start to even just touch on the topic of narrow networks is the, potential limitation. So there are ways to address that limitation by having these different types of tiers, so that you don't have, whether it's executives or just any, portion of your employee population that's, concerned about their access points. You can still provide access points, but there might be difference in cost share depending upon where you are accessing your care. So the option can still be there, but if they shop effectively and they go to that tier one, then they would end up paying less in the patient cost share simultaneously. So that's the combination that you can layer with a solution like this.
Right, exactly. And two additional points before we move on to the next section is that when you're working with a narrow network and a direct to employer relationship, given how big health systems are today, you're going to have some of your population already going to that network, right? So what we do on a pre-sale analytics process, we're able to show an employer, hey, you already have 40% of your utilization or 50% of your utilization going through our network. By adopting this model, you save that 20% overnight on that population that's using us because we are in this region, right? And then you create a plan design to try to migrate that utilization to north of 50% and really drive savings through the plan. And the other thing that I forgot to mention was how do we handle people that live outside of this area, right? Or outside a narrow network in general. So it's really important, obviously, for those members that wouldn't have access to a Northwell Direct. What we do is we create a benefit plan where it's an out of area plan, but the member, depending on what the employer wants to do, can create the tier one benefits as you see here today as just the Aetna network. So if you live in California, you'd have access to the Aetna network at the tier one benefit structure, or some employers say, you know what, I'm going to keep it at tier two for those employers. Since it's a self-funded ERISA plan, the employer and working with a consultant can structure that out of area plan however they want, but it's just the traditional way someone accesses care would be, in this example, the Aetna network, one tier, and every single provider and hospital that's in the Aetna national network in that area would be subject to the plan benefits that the employer decides on for that population.
Great, thanks, Drew. So we've talked a little bit about the value behind the program or potential programs, and we've talked a little bit about the structure and how you can integrate a solution like this. And the examples that Drew's providing are, kind of specific to some of the scenarios that he set up, but we've also seen very similar options from other narrow network providers out there where there is potential for tiered approaches. So wherever your employee population and whatever that footprint might be, there is still potential that a narrow network could work depending upon depending upon the analysis that you do. So I think that's, one of the key takeaways when we look at that integration is that there are ways to integrate without being disruptive, too disruptive at any given point. So as we kind of transition now, we've talked about that network and about the structure of it. Wanted to talk a little bit about some of the other components that you will frequently see in addition to the discussion around the network itself. And we've kind of, for simplicity purposes, broken them into two categories, and that's the clinical element and then the well-being, wellness, or member support. So the clinical element is also a very important piece. It's usually a secondary piece to a discussion around narrow networks because you're talking about, is there a cost value? What would that cost value be? So that's really one of the first steps that happens. But when we're assessing a narrow network, we do want to really dive into clinical programs that are also in place behind the scenes, because you can have a great contract in place with a given provider, but that alone isn't a sufficient driver to ensure the sustainability that we talked about earlier, because you can have an inexpensive knee surgery, but if at that facility people are having to go back to have corrective procedures done, or they're having some type of reentry, you now have a clinical situation on your hands that is going to end up ultimately down the road being more expensive. So having clinical measurements and having clinical programs to ensure that there is monitoring that's being done and that there's a strategy in place can be as important as the negotiated pricing structure that might also be in place. And that's something that most of the networks and the partners that we see are building out and really focusing in on. And not every network solution is going to have the same type of clinical programs or clinical focus. So when we talk about the analysis that'll be coming up next on taking a look at what might be the right fit for you, looking at those clinical components is a key part of it, usually a secondary part, but it is a key part. And then there's also the element of, if you're going to offer a program like this to your employees, you want to have them see the value as well. And that value, like we talked about, might be in cost sharing from a contribution standpoint, what comes out of their paycheck. It might be cost sharing at the point of service. They could have a lower copay, but there can also be value with some of the well-being programs and some of the member support, because if you can get a vested interest from employees and from their families, that's how you can encourage enrollment and encourage a more positive overall experience with a program. And some of these networks are very well positioned to be able to offer both the clinical and the well-being elements on that. So I'm going to give Drew an opportunity to talk a little bit more about some of these types of programs that Northwell Direct has in place as some examples to kind of build out around these two topics. So Drew, I'll pass it back to you.
Great. Yeah, thanks, Travis. Yeah, the first part of the presentation, we talked about a direct to employer relationship with the health system, from a price standpoint, right? To the unit cost, what it costs to actually do a service. But the other part that we want to think about when working directly with a narrow network or a health system is the care management model. And I think both ways is they kind of complement each other in a sense that we're closer to the patient than a traditional insurance carrier is. Right. So in the first part, the contracting, we can create some synergies and some value to be able to provide that lower rate, because there's a lot of administrative complexities that doesn't have to happen with a direct to employer relationship and a narrow network in this sense. But from a clinical care management perspective, we are closer to the member, right? We're the one providing the care. We're the one that is seeing the patient when the service is incurred. A lot of the traditional models have to wait for the claim to come in. So in real life, if I go this afternoon to go see a specialist and they diagnose me with something, or I have to have a procedure and then it gets pre-certified, the procedure happens, typically I don't get put into a care management model until that bill is submitted by the provider, gets to the carrier, it goes through the system, then they provide outreach. When you have a direct to employer relationship through a health system, we are able to access the electronic medical record of when that member is seen to put into place different care management models and disease management programs to reach your populations faster. And why that is important is that this is going after the population that is driving 80% of your spend. You have 20% of your population that is making up 80% of your spend. So being able to get those folks and get in front of them before they leave the four walls of a health system, before they leave the hospital, providing that outreach to the member, the primer to them, saying, hey, we just diagnosed you with diabetes. You're going to get a call in 24 to 48 hours about a diabetes disease management program. As your provider, I think it's important for you to pick up the phone and actually listen to what they have to say and enroll into that program, because it'll be beneficial to you from this recent diagnosis of diabetes. So the carriers and the TPAs in general, since they don't have access to the patient like that, they struggle with getting people to answer the phone, call them back, respond to emails, because it's just, I think a lot of us on the phone, we've come across that relationship with an insurance carrier that they're calling me up to deny a claim or wrangle for me for money. But what we see from our end, we see adoption rates and engagement rates and enrollment into these programs 5 times higher than the traditional models, because when the phone rings, it's the health system calling that you were just at. It's the provider calling when it says Northwell on the caller ID, or when the message is left. There's just a different psychological relationship with the provider of care versus the payer of care. So we've tried to adopt this model with our team that we call Health Solutions, to provide this care at the right time, the right place for the member, but the right patients that we're going after. You want to manage the high utilizers, the chronics, right, that are going to be on your plan for the lifetime of employment. I mean, a big thing these days is, yes, you have your traditional cancers, you have your traditional inpatient procedures, but specialty medications. Crohn's and colitis, for example, these drugs are running anywhere from $10,000 to $20,000 a month, and it's a maintenance medication. They're going to be on the plan for the lifetime of employment of either that employee or the dependent. So what are the different ways that we can access that drugs in a different way, or try to get manufacturer assistance for these members? So really just jumping in and trying to help out across the whole healthcare continuum to drive those savings, not only on a unit cost, but these soft dollar savings where, as Travis mentioned, a redo procedure or a readmission rate into the hospital is avoided. So we flip to the next slide. We can just give a high level overview of who the Health Solutions and Care Management team is at Northwell Direct. But I think in general, you'll see different programs in place with bigger health systems, regardless of where you are, that are doing this predominantly for their own population, right? Their own employees that work in the health system. Typically, they take the approach that we know our people better. We're closer to the care. We're going to handle this for our own people, opposed to a traditional carrier model. And then you see the names at the bottom in the local market here, right? Working with a lot of Medicaid and Medicare agencies for the membership in fully insured populations, as well as the New York State Department of Health and the CMS nationally. But it's a program that we have about over 400 nurses working on for 300,000 lives. So every one of our Northwell Direct clients is enrolled into this care management program. But from a health system standpoint, since it's a concrete example, we're nonprofit versus on the payer side trying to drive to earnings in Wall Street. We have 400 people for 300,000 members working on that book of business. So if you looked at ratios with us compared to traditional models, I think we're at like 1 RN to 750 people, right? Versus on a traditional model, you might have 1 RN signed to a book of business of several thousand, upwards of 7,500, maybe 10,000. So the point is, by the model that we've instilled, we have access to the patient earlier. We have electronic medical records where we can use that information and provide outreach to our population way before a claim comes in and is processed from a TPA or an insurance carrier, and then just have the ratios of the staffing model that we have to serve that population, where if you have more people assigned to a population, it's going to create more outreach, more conversations, longer conversations, and net results to the health plan in savings, those soft dollar savings that we talked about earlier. And then the other thing, the last part that we'll talk about, and before I think we jump into the wrap up and Q&A, I'll go over real quickly because I think we're coming up on time pretty soon, is what we do on the other side of the business when you have a direct to employer relationship like Northwell Direct or different health systems that are offering these services in the communities that you might be out there. But is these different services that we can provide on-site, near site, or virtually, whether it be on-site flu shots or biometric screenings. We did a lot of work with COVID on-site testing and vaccinations. We have programs in place that we are doing from a mental health capacity. We have a 24/7, 365 mental health crisis management line for the New York City Police Department for their 36,000 officers. A lot of times when we're speaking with employers, we hear about the limitations around access and navigation in the behavioral health side of a healthcare plan. And a lot of things we hear is that it's really hard for me to find an in-network provider. And then when I find an in-network provider, I can't get an appointment for a month or 6 weeks. So what we've done with the dozens and dozens of practices that Northwell owns in the behavioral health space, we've created a program where we can provide a dedicated line to an employer, have them meet with a master level therapist right away, and then be guaranteed an in-person appointment in 2 days, whether virtually or in person. So breaking down that access to care, because it's a different model when you think about it, right? A provider's office has a lot of people answering the phones, and a lot of providers, and it's a pretty multi-dimensional place. But when you get to behavioral health with psychologists and psychiatrists, a lot of times it's a one-person office where they are checking voicemails when they're in between appointments, or they're with patients all day and they call you back at the end of the day. So creating that access and navigation around behavioral health. And then we provide a lot of services for concierge medicine, creating dedicated lines for employers to access care through the Northwell health system. So these are all programs that we have in place that we're able to either have off-the-shelf products for employers in our area, as well as bring customized programs, whether it be in person, near site, or virtual, to employers outside of the network that we just talked about. So these are services that we can offer to employers outside of their traditional health insurance plan that sit on top of, or work in tandem with their current offering.
Great, thanks, Drew. And I think, one of the key takeaways from some of the programs that Drew just described are that there's an opportunity for some, very high touch, high value, almost, can feel like a concierge level of engagement that some of these types of programs that can offer. Again, kind of circling back to the idea that although the network may be narrowing, there are other areas that could be expanding simultaneously. And that can be where, whether it's on the clinical side, like we talked about, or some of these additional and add-on services that can really bring some value both to an organization, but then also just to that individual, to that patient who's going through a particular process or needs a particular type of service. That additional touch point and support can, be a very positive interaction for individuals. And we generally like to encourage that, because positive interactions around benefits tend to have employees think more positively about their work as a whole. So we like to see these types of programs in place whenever possible. They aren't necessarily always the drivers, but they are certainly bringing that additional value. And like I said, having a higher touch kind of approach to benefits and to the medical program. So as we kind of wrap up our discussion here, we want to move into what are the considerations and how do we want to analyze a narrow network to determine if it's the right kind of fit for us. And not surprisingly, you're going to see some repetition here, because we're going to talk about geography, outcomes, cost again, finding that right combination. But when you're fully insured, the analysis is a bit quicker, because you don't have quite as many components that you need to review on your own, or frankly, even that you're able to review on your own, because the insurance company is managing that risk and they're going to price it. So when they provide quotes for different plan options, just like if you make a change to the deductible, if you talk to a carrier in a fully insured arrangement and you ask them and start working with them to see if they have any narrow networks or customized networks or whatever their nomenclature might be, but the concept is the same, they're going to have a value that they're going to put on that. And you might be able to very quickly analyze, okay, here's the value for the standard network, and here's the value for a narrow style network option, and what are the pros and cons on that, and then what would the ultimate savings be. So when you're outsourcing that risk in a fully insured arrangement, you're really relying on the carrier to provide you back with what that differential is, so that you can do your analysis and start to weigh, would this be the right fit for you? When you're self-funded, there are multiple moving pieces that are going to happen simultaneously when you start to consider, is this the right type of fit for me? So irrespective of your funding arrangement, step one is always a thought around geography and determining do we have the potential to be able to offer a narrow network? Because just as we've been talking about today, and as you've heard from Drew, their focus is in the New York metro area. Many of the narrow network options are going to be geographically specific, maybe to a metro area, maybe to a state, or maybe to an area like the Mid-Atlantic where you're looking at, Virginia, DC, and Maryland. So there are typically going to be some geographic focal points that are going to happen. And that's what you need to talk to your consultant about. Start with that census, figure out who are the potential vendors that might be able to bring a product to the table for us, and have that vendor do a geographic analysis for you. Drew mentioned this before, they do geography and cost analysis. And that geographical piece of it is really phase one. So once you find that you have a footprint that you can install, then we start to look at the next steps of that. And that's really going to be around the outcomes and the cost. So Drew mentioned before, they do a cost analysis. So when you're self-funded, you have access to a significant amount of data. So what most of the vendors that provide a network solution like this are able to do is look at your historical claims and run them essentially through their system to determine, would there be a reasonable value? Would there be a cost savings? Is there an opportunity here based on your claims over the last 12 or 24 months? Now, that's a look back to help us predict what might happen in the future, but it is the most effective way to do that. And if you can work to determine and review a reprice of your existing claims, you can really start to get a concrete number. Because some of what we talked about today are average discounts and average amounts that you might be able to save with a given program. But when an opportunity arises to be able to do that cost repricing, then you really get to see, okay, we can now measure our own claims to determine, is there a value to this program? And then a secondary piece of that is also talking about the outcomes, talking about the focus. What measurements are in place? How are they developing their contracts? How are they measuring the outcomes of those contracts? What type of clinical programs are in place? Especially when you're self-funded, but also fully insured. With access to data, you're able to see and get some window of insight into what are our primary drivers from a medical and prescription standpoint. And you can get a sense of, okay, these are our main chronic conditions, these are our high claimant conditions, these are the main facilities and hospitals that we're going to. And if you can start to work through that data to find the patterns, finding a partner that is also addressing maybe perhaps those same conditions or working in that same geography that meshes with your actual claims, you now find the right overlap to bring the highest level of value with a program like this. And for our clients, we've gone through quite a few analyses around, is a narrow network a good fit? Sometimes we get through phase one and the geography works, and great, now we move into phase two. And sometimes we do a reprice or we look at a cost solution and maybe that value isn't there. It's all about determining what your goal is, how you might be able to take that next step with that analysis. So phase one is the geography, and then phase two is really that outcomes and that cost piece. And ultimately, as you go through this process, the numbers will really start to point you to a particular direction, determining, is this something that could ultimately work for us? Or is it something that we might want to, put on the back burner for a while and maybe revisit as our claims changes or as our, population changes over the course of the year or multiple years. So these analyses can be done really on a regular basis, on an annual basis, as part of your benefit analysis and benefit assessment. So I'm going to take a quick second to just check and see if we've had any last minute chat questions come in. We are actually getting very close to the time that we had allotted, and I don't see any questions that we haven't already touched on coming through the chat. feature right now. So I think at this time, we want to thank everybody for taking some time to discuss narrow networks and hear from Drew and I about some of our thoughts around the analysis of networks and what they can bring to the table, and for Drew bringing some of those specifics about their program, so you have that direct and inside kind of vantage point. And hopefully everyone was able to take away some next steps, either just from an informational standpoint or on what you would do next to be able to analyze a narrow network. So talk to your account management team, talk to your consultant if you think that this is something that you'd like to explore a little bit more. But we really appreciate you taking your time. Thank you so much for being with us today. I know Heather has a couple closing pieces here for the credits that she'll walk us through now. So I will pass it to you, Heather. Thanks.